Welcome to Health IQ. I'm Alan Siegel. Tonight we have a special guest, Dr. Jason Hochfelder. He's an orthopedic with Hudson Valley Bone and Joint, if that's correct?
That's correct.
Welcome. How you doing today?
Oh, very good. Thank you for having me.
Great, great. So this is kind of special for you. This is not too far from where you grew up. You're from the area in Briarcliff, correct?
Yeah, I grew up in Briarcliff Manor, lived there for 18 years until I went off to college.
And you're an athlete as well, growing up in the area? Played some baseball?
Yeah, I played quite a bit of baseball and even continued playing baseball throughout college as well.
So full circle now, you're an orthopedic surgeon and you've come back to Westchester to practice, so we're happy to have you. I'm sure some of your family and former teammates will be happy to have you too down the road. So you are specializing in mostly knee and hip issues, correct? That's where you focus in your practice?
Exactly. The majority of what I do is hip and knee surgery.
Okay.
In my training throughout orthopedic residency and as well as in my fellowship, I did a focus on hip and knee surgery. I do a lot of joint replacements as well as joint preservation work as well.
Okay, so the knee is a sort of a complex joint, right? You hear a lot of different things about the knee, sports injuries, meniscal issues, cruciate ligament issues. At what point, when you're discussing these things with your patients, when you know they actually need a knee replacement? Like, what is the difference between having to replace a knee versus just a typical sports injury?
Great question. So typically, younger patients who have injuries generally don't have severe arthritis, meaning the cartilage in their knee, and if you think about like a chicken bone, the white shiny stuff on the end of a chicken bone, that's your articular cartilage. When that cartilage starts to wear away, which happens over time from a lot of wear and tear, that's arthritis. When you have severe arthritis, that's when you start needing to think about joint replacement surgery as opposed to fixing things like the meniscus, which is the cushion inside the knee, or the other ligaments, which typically happen as injuries in athletes.
So it's a different part of the knee where it starts to get degenerative and starts to wear down a little bit. So it's the actual cartilage. I have a model here. If you could just kind of show the viewers exactly what we're talking about here.
Sure. So this is a model.
Tendons a little bit.
Yeah. So this is a model of the knee. In the front is the kneecap, which is called the patella. Up top is the femur, which is the thigh bone, and down here is the tibia, which is the shin bone. If you pull the kneecap aside, everything that's blue here represents articular cartilage.
Okay.
That acts like a cushion for the joints. The meniscus inside, which is this brown material, which is commonly torn in athletes, and as well as the anterior and posterior cruciate ligaments, which are on the inside here. Those are injuries that sometimes happen in athletes from twisting or turning or being hit. The articular cartilage, which is the blue stuff on the end of the bones, that can wear away over time from just gradual pounding, being overweight, general wear and tear. So when the cartilage is injured, generally that's a patient that will need a knee or hip replacement if we were talking about the hip.
So it's not the meniscus that some people get confused. The meniscus is what kind of wears out. It can get worn and torn and damaged as well, but that's not really what's causing the arthritis per se.
So when I think about tears of the meniscus, I think about them as two distinct types of tears. You have a tear in a young athlete who is playing soccer or playing football and they twist and turn and then they tear the meniscus. But in that person, their cartilage on the end of the bone is all fine.
It's still healthy.
So in that person, you can repair the meniscus, or if needed, you can get rid of the tear.
Right.
In an older person who's had a lot of wear and tear and has a lot of cartilage damage, this end of the bone becomes very rough. And when you have a rough surface rubbing on the meniscus can then become torn because it has a rough surface rubbing on it. In that type of person, repairing or fixing a meniscus tear is not necessarily going to be the best thing for them, because if you fix the meniscus tear, you still have the arthritis and the rough surface there. Right. So you can fix it, but you're just going to be set up to have a re-tear. And in that case, a replacement operation is probably.
You mentioned like elderly or maybe people that are aging a process. Typically, people think of joint replacements, a little bit older population. But are you starting to see, or is there a trend where people maybe in their 40s and 50s and 60s are starting to have a little bit more complex situations that maybe they didn't have years ago, or
Yeah.
maybe they couldn't do anything about it years ago, but now they're...
Absolutely.
Yeah.
With the active lifestyle that people are living these days, and is also with people being more and more overweight. Unfortunately, we're seeing people at a younger and younger age come in with arthritis. Years ago...
Now, would you say there's a correlation, like as a doctor, would you consider a weight problem that we do have in this country, obesity, as people would call it, causing the joint stresses? So some people say arthritis is genetic, sometimes it's overuse, sometimes it's a combination of all those things, but
yeah, I think, as you said,
yeah.
it's definitely a combination of a lot of
Yeah.
things. There's definitely a genetic component. There's definitely a wear and tear component, which is from people just beating them up, doing a lot of activities. And then the more you weigh, the more force that your joints are seeing, so the more and faster they're going to be worn out.
So the weight-bearing joints, hips and knees, ankles,
Exactly.
Even lower back and spine to some degree. Okay,
Absolutely.
So when you're assessing a knee, people think, what actually is a knee replacement? What is, what exactly is being replaced? And like, are they cutting the femur? Are they putting a whole, new femoral condyle up there? Is it just partially being done? There are different, reasons to do different types of surgeries. Partial knee replacements are something that's become a little bit more, I guess maybe less invasive based on what the conditions are presenting with. Tell me when you would, do
Sure.
a partial versus a full knee replacement.
As we showed on the model,
Yeah.
the knee has the three areas: the lateral, which is the outside; the medial, which is the inside; and the patellofemoral, which is under the kneecap. When only one of these areas is worn out or worn away, you can do a partial knee replacement, which is a less invasive procedure. It's done through a smaller incision, and the recovery is generally faster, and the mechanics of the knee joint are kept much more natural. When 2 or sometimes 3 areas of the knee are worn out and have severe arthritis, if you replaced only one area, the patient would likely still have problems from the other areas of the knee being worn out. In that patient, a full knee replacement would be the best option typically.
Okay. Now, if you did a partial, there's not to say that maybe the other part of the knee doesn't eventually wear out. Is that a complicating issue if you have to go back in, or you just do what you did on the other side as a partial when it needs it?
Yeah. That is one of the controversial aspects about partial knee replacements, is that you're leaving a lot of the patient's normal knee.
Yeah, the unknown, like what could happen. Yeah.
Right.
Yeah.
Which is why the most important part of doing a partial knee replacement is not necessarily the surgery itself, but doing it for the right indications.
Right.
You want to do it in someone who has only isolated problems in one area of the knee. And also, you want to make sure that that person's symptoms correlate with the area, meaning if they have pain on the inside of their knee, and that's where the x-ray shows the arthritis to be, then that person would be a good candidate. If they have pain throughout their entire knee, and even if the x-ray shows that only one area is worn out, you might think twice about doing a partial replacement in that person.
Gotcha, because the likelihood is that you'd like it last as long as possible and not have to go back and do a secondary procedure.
Right.
And some of the technologies are changing.
Right. At least in my practice, I never would want to do a partial knee replacement in someone who I think that it's only going to last for a short period of time. Whenever I'm doing a joint replacement operation, be it a partial or a total knee replacement, my hopes and my goal is for that to be the patient's only operation that they have in their life.
And I guess with newer technologies and new materials that are being used in the actual replacement parts, they're hoping that they do last longer and longer nowadays.
With partial knee replacements as well as with full knee replacements, years ago the thinking would be hold off as long as you can because it might wear out and we never know how long that these implants are going to last. But with the newer technologies and the newer implants and the newer materials that we have, we're finding that these things are lasting longer than ever before. So that's why people younger and younger are having these replacements, because we're finding that the replacements are lasting longer and longer.
Truly true bionics, right?
Yeah, exactly.
Now, procedural-wise, there are new techniques for doing these types of procedures. I understand, robotics and instrumentation and digital CT evaluation of ththese joints are becoming, more common and definitely more prevalent in the industry. I understand that you do some specialty work with what's called Makoplasty or the Mako machine. Describe a little bit about what that is and some of the advantages of that versus maybe some, to use the word older techniques that are still very viable, but how would someone do with the robotics?
Well, just to start off, the traditional way of doing a total or partial knee replacement would be for the surgeon to go into the surgery and use essentially their experience and their eyeballs to take a look at the knee and hopefully make the cuts and all the parts of the surgery, as best as they see comfortably and as best as they see fit. Now with all the new technologies we have, that way of doing things, while still very good and many people are doing it, has, I think, been replaced by robotics. The partial knee replacement that I do with the robotic assistance is when a patient gets actually a CAT scan beforehand, which gets uploaded into a computer, and the entire surgery is actually planned out before the patient even sets foot into the operating room.
So it's like a mapping of sorts. They map out the knees, the joints.
Exactly.
To some degree. Okay.
We can try different implants on the patient using the computer models, see what fits best and see what works best for that patient's specific knee. When the patient ends up coming to the operating room, we put trackers on their knee, so wirelessly their leg is actually communicating with the robot itself. And then, because we're using a robot which is so precise, we can actually make smaller incisions in order to do the surgery more precisely. And the robot actually will help us plan out the operation. And in addition to planning the operation, it will help us do the operation and make sure that our cuts are in the exact specific spot that they should be.
All right. That's very interesting. We're going to take a quick look at a video just to show our patient. If you could just describe a little bit what's going on, just like you were saying.
Before now, the robot has already planned out the surgery as well as the computer. And now this arm that's being shown here is attached to a robot. And the robot is actually making its cuts and taking away bone in the exact specific way that we planned.
Now, is that the cartilage right there that's taken?
Right, so
yeah,
that's the cartilage as well as a little bit of the underlying
of bone. Okay.
In order to make room for the implant, which you see coming in here right now.
Okay.
When knee replacements or partial knee replacements don't do well, it's for one of two reasons. It's either because the knee replacement was done in a patient who didn't need it, or because for the wrong indications, or because it wasn't done perfectly. It's my job to make sure that we're doing it for the right reasons, and it's the robot's job to make sure that it's being done perfectly. So essentially, doing this partial replacement with a robot eliminates a lot of the reasons that in the past people have had problems with partial knee replacements.
So it takes out some of the guessing out of the cutting and the area that the implant needs to go into. Basically.
Exactly. One of the nice things about doing this is that I always know that after I do the partial knee replacement with the robot, that my x-rays are going to look perfect.
Right.
So
because everything lines up properly. So.
Right. So a lot of surgeons, when they do the replacements, they're waiting for the x-ray to come afterwards, and they're nervous about what it's going to look like. I hope that I did it well. Right. When I do it, I know that it was done perfectly.
Right. So it's a confidence booster for sure when you're going into the surgery.
And as you said, it takes a lot of the guesswork out of it.
Now, are you doing just partials with this type of technology, or full replacements as well can be done with this technology with robotics as well? Or it's a different procedure really for the...
So we're right on the fringe right now of a lot of exciting things happening with partial and total knee replacements. I think the technology out there for partial knee replacements with the robot is really excellent. We are doing some work with total hip replacements, and really, the next level of technology and really what's on the horizon is robotic assisted partial knee replacements is probably the next breakthrough in
okay,
in
so that is common, and
it's coming right around the corner. Yeah.
That's great. And then from a minimally invasive procedural work, this technology does help create less cutting, possibly. It's a little bit easier to get into the joint, or is it about the same?
Right. Well, because with the traditional ways of doing hip and knee replacements, in order to, as I said before, the surgeon to make the cuts accurately, he or she really needed to get a great look
and so you got to open
see
up
exactly
more.
what was going on.
Right.
In this case, with the trackers on the patient's leg, communicating wirelessly with the robot, we don't have to make the incision as big to take a look at everything, because the robot knows exactly where the patient's leg is, and we can make smaller incisions, which hopefully should lead to a faster recovery for the patient.
Okay, now before a patient would go for a knee replacement, there's a lot of things that, like we said, go wrong with the knees, and just prevention of knee problems in general, like you said, you never know when injury is going to occur. You're on the soccer field, you're playing football, you're doing whatever, running. There are other procedures that some doctors work with, Synvisc, Orthovisc, different types of injectables. Have you seen success with those, or have you used those in your practice, or seen patients that have had some success to preserve some of the joint for a period of time?
Yeah, absolutely. There's two patients who we traditionally use a lot of these injections in. One are patients who are not quite ready to have a joint replacement operation. Their knee may be a little bit too worn out for some of the less invasive surgeries, like an arthroscopy, where we stick cameras into the knee through micro and sort of 1 centimeter incisions. So it may be too advanced for that, but it may not be advanced enough to warrant a knee replacement.
Right.
But they're still experiencing a lot of pain. And in these patients, we give, as you mentioned, cortisone shots, which help decrease the inflammation, which is caused by the wear and tear.
Right.
And then the shot that you mentioned, Synvisc, which is essentially a cartilage substitute made out of a material that's naturally occurring in our bodies, is injected, and it acts almost like a lubricant in the body.
Lubricant. Just keeps the joints moving a little bit.
So these two materials work in partnership with each other, where the cortisone decreases the inflammation, and then the other material acts as a lubricant. And the second type of patient we do it in are patients who are maybe too sick to tolerate a full joint replacement, but they're still experiencing a lot of pain, and they want some relief.
Now, do you find if patients are in better physical health, obviously you want them to be as healthy as possible prior to surgery, but physically as good as they can be in terms of quad strength and lower leg strength, and just generally in good shape before the surgeries that help with recovery?
Absolutely. Yeah. We actually have a term for it that we use. A lot of our patients who are undergoing hip and knee replacements, afterwards they'll require physical therapy for strengthening and range of motion. And after surgery, we call it rehab. Before surgery, we call it prehab.
Prehab, right.
So yeah,
right.
so often we'll send the patients
that
for strengthening exercises before surgery.
Just to get
as
them,
you mentioned, the better shape you're in going into it, the easier and the faster that you're recovering.
Because people don't think about it sometimes, but I think we in our practice we do see patients that are motivated to really have the best recovery and the best outcome, and they do put in that work before surgery. People don't think about it because their knees hurting them or this is hurting them, and they're like, I can't do anything. Well, we can work around the pain sometimes to still get those parts of the body strengthened that we want to get stronger. So I think it's important. So that's why I just wanted to bring that. Now, we're leaving the hip out here. We're talking about the knee all night, but we haven't spoken about the hip. So there are different procedures that people do for hip replacements, in terms of anterior versus a posterior. And I spoke to you a little bit before the show, and you do both, maybe preferring an anterior hip, but tell me the major differences between the two and why one may have certain advantages over the other for the patient.
Sure. So as you mentioned, there's two ways of doing a hip replacement. Anterior, which is done with the patient lying on their back and done through the front, and posterior, which is done with the patient lying on their side and actually done sort of through the side of the leg. One of the major advantages of doing it through the anterior approach is that muscles don't need to be cut. We actually spread and go between muscles, and because of this, there's a lot less trauma to... So
there's no muscles being cut at all?
No muscles being cut. You're
kind of go through the muscle
interval
fibers,
that you get to the hip joint is between two different muscles.
Right.
When you do the hip replacement through the back, which is the traditional and sort of the tried and true way that's been around for many years, a lot of muscles need to be detached from the hip in order to do the hip replacement, and then later reattached.
Okay.
Because this causes extra damage, it sometimes can cause a delay in the recovery and a little bit slower recovery. The other issue is that because you're detaching muscles and reattaching them, you can actually have a greater chance of dislocating the hip after the surgery.
Because of the stability of the joint?
Exactly.
Yeah. Okay.
Doing it through the front doesn't eliminate completely, but decreases your chance of having a dislocation or the hip popping out of place after having a hip replacement.
Okay. Well, they don't want too many hips popping out, so
No, we don't want that.
But the risk is there. Now, anterior, you have other structures to deal with, arteries, other issues. Are there any, obviously a skilled surgeon hopefully will leave those arteries alone, but maybe there's some other risks that involve an anterior hip versus a posterior hip.
Sure. And actually, the interesting thing about anterior hips is that we think of it as sort of the newer way of doing things. However, anterior hips have actually been around and been done in this country for 30 or 40 years. And what happened is 30 or 40 years ago, when people started doing anterior hip replacements, they didn't have a lot of the technologies, a lot of the tools that we have today. And so they were finding more and more complications, such as broken bones or the area around the hip breaking, lots of extra bleeding because, as you mentioned, there are blood vessels in that area. And people abandoned doing the surgery for many years. With the newer technologies we have now, the newer instruments, and even new operating room tables that we have, as well as new implants, the operation, meaning doing the hip replacement through the anterior aspect, has actually regained popularity and become much safer than it was many years ago. And because of the advantages with increased recovery and faster recovery, more and more people are opting to have their hip replaced via the anterior approach.
Okay, so again, technology just improving just everything that's going on. Now, you mentioned, some of the tables. I know there's a table called the Hana Table. Patients may not be aware of it, that they're even on it probably, but because they're usually under. But tell me about the table. What is it? Is it a positioning thing? Does it help the doctor get into that joint a little bit quicker, a little bit easier, in the right position?
Yeah. So the Hana Table, as you mentioned, is a table that we use that assists us in doing the anterior approach. The patient actually lies on a table with a post in between their legs, and then they have their legs actually go into what look like ski boots and that are attached to the table. Because of this, there's someone who's not scrubbed into the operation, meaning they're not actually part of the operating team, is adjusting the table and allowing you to move the leg around in ways that you couldn't do without the table in order to improve your access to the hip joint and facilitate the operation. One of the nice things about the table as well is it does not show up on x-rays, which means that you can use an x-ray machine during the operation
to help guidelines.
Exactly, to make sure that your position of your implants are in the exact right position, as opposed to when you do it through the posterior approach with the patient on their side.
What's the table made out of that doesn't show up on x-ray?
That's one of the...
It's like a B-52 bomber or something.
Secret technology that we're not allowed to know about.
Right, that's pretty impressive though, that it could not show up on x-ray, because you would think there
it doesn't
would be some metal or something.
Yeah, it doesn't interfere with our x-rays. So during the surgery itself, we're taking an x-ray. If we don't like the position of the implant, we can move it and keep taking x-rays until everything is in the exact right position. As opposed to doing it from the side or the posterior approach, you don't have the use of x-ray, and you have to wait till after the operation to take a look and sort of hope that your implants are in the right spot.
That's great. Now, in terms of we're talking about a lot of joint replacements. That's like, okay, you're getting the joint replaced. There's no going back. Now, what about preservation of joints? People are starting to ask about, cartilage replacement technology, and we spoke a little about the injectables. What else can you do as a surgeon, or what else is to sort of preserve hips or maybe preserve knees or something to give them a little bit more longevity without having to go in for a full invasive procedure? Like they use the word, hip preservation or resurfacing.
Right. So there are a lot, as sort of the theme is today, there's a lot of new things on the horizon. And one of the new things is actually not even surgery itself. We talked about a few other injections before, the cortisone and the gel injections. Two new injections that are on the horizon are one thing that's called PRP, which stands for platelet-rich plasma, which is actually when we take a patient's own blood, isolate a lot of the growth and healing factors, and then can inject that into the knee or the hip. And then the really newest thing that's out there is something that is called stem cells, where we actually take bone marrow from a patient's pelvis, once again spin it down in a machine and isolate the growth factors and inject it in. There's not a whole lot of research out there on it, but the preliminary research does show some promise that it can help delay and potentially even repair some cartilage damage, although that's not as
So they're looking to actually, repair cartilage, which is really the crux of what a lot of causes the replacements, is when the cartilage is just not there anymore. That's what. But if you can get some replacement in there or some regeneration in a younger athlete or a younger person that just maybe isn't ready for the surgery.
Right. And then there are other, if all of these things fail, or if a person's not a candidate for these type of injections, or even if they have just one specific isolated area of cartilage damage as opposed to damage to the whole joint or a whole section of the joint, we can actually go in and put little plugs of cartilage into the one, what I call a pothole. If there's a little divot or a pothole, we can take plugs of cartilage and plug it in. And even some of the newer things that are out there are where we can take biopsies of people's cartilage, send it to the lab. They can regrow the patient's own cartilage, and then we can put it back into the area where the cartilage is missing.
In a very small area, or very
exactly
pinpoint area.
It's important to understand that these type of surgeries are not for people who have diffuse damage throughout the whole area. Those people would be better suited for a joint replacement. But if someone has otherwise healthy cartilage, but either due to trauma or because of their mechanics or for sometimes unknown reasons, they're missing cartilage in only one small area, there are things that could be done that are not replacements for the whole area, but actually just replace the cartilage in one specific area.
Now, is that resurfacing, or I've heard that term before,
no,
so that's a little bit different?
This more fits under the area of joint preservation, as you mentioned before, where you're at the beginning stages of arthritis where you do have damage to that cartilage that we talked about before, but you don't have widespread damage. So we're hoping to preserve the joint in order to not need to have a replacement.
Gotcha. Okay, that makes sense. Well, look, we spoke about a lot of different things. Obviously, technologies are changing rapidly in medicine, and all for the better, I think, for the patients. And surgeons like yourself who have gone through extensive training to learn about these new technologies to bring them to the forefront of medicine, I think is really important. And that's one of the reasons why we like to have professionals like yourself on the show to get this information out there. So if you have any last questions for me, or just we'll wrap up the show. But I think it was very educational for the patients, and I want to thank you for being here. All right, so good luck with your new profession here up in Hudson Valley, and we're happy to have you. So thanks for being on the show.
No, great. Thanks for having me.
Thank you for watching Health IQ. I'm Dr. Alan Siegel. See you at the next show. Thank you.